My name's Justin Lee. I'm a consultant radiologist at Fortius and Chelsea and Westminster. I've got a special interest in sports imaging. So yeah, I'm one of the Olympic radiologists, work with lots of Premier League, football and rugby. Thanks for coming, amazing turnout tonight. So yeah, brilliant, well done. Right, so first of all, my bit, unsurprisingly, is to talk about imaging, and I'm going to talk about lower limb overuse injury. So how many times do we see these injuries? Well, unsurprisingly, in running, it's probably high in this bit, and if you take all sports together, 75% of athletic injuries can be defined as overuse injuries. Now, obviously, that will change from sport to sport, but if you take all athletic groups together, this is the numbers that you come out with. As we get older, we do tend to move away from team sports and go into individual sports, so and inevitably they become endurance sports, because actually, if you look at endurance sports, the difference between a young man and an old man is not quite as wide as it might be for a more explosive sport. But essentially it's the same. Whatever the outcome, whether it be a muscle, bone or a joint or a tendon problem, it's always the same. It's repetitive microtrauma and not giving yourself enough time to recover. And then you go further with trauma. So how do they present? Well, it's a very wide variation. But if you group them together and say, well, how does it present an overuse injury? Well, you can talk about a defined performance limitation. That is, that is definitely true. You see that in your patients, you see it in yourself. You're not performing to your maximum capability. And there can be a small, subtle effect. And one of them, this last thing, lack of confidence in the affected limb. Again, I think you'll see your patients, and again, if you're athletic yourself, this idea that you don't want to push the limb because you're worried about it, and then again that has an impact on your performance. Now, this isn't a hard and fast classification. This is just how I do it. If I'm assessing some imaging of an athlete who's got an injury, I might decide to look at it in this way, which is that I'll look at the bone structures, I'll look at the joints, the structures around the joints, and the tendons and the muscles. So I'm going to talk about bony injury because really this would make up a very large proportion of running-related overuse injuries. And that's various names, shin splints, but really it all refers to bone stress, and it varies from a stress response to the end result being a stress fracture. So up to 10% of sports medicine practice and imaging is a bony overuse injury. It's a medial or posterior pain on exercise, and principally starts as a periostitis. It can be very tender, but the patients will report it after a certain period of time running. It's a classic presentation. So what else could be causing it? Well, there are some of the soft tissues around the border of the tibia, which also get inflamed. And we do see that in extreme cases, that you get a very marked inflammation around tibialis posterior. Now, the traditional way of diagnosing this was to do a bone scan. But essentially, if you look at shin splints, you get this linear, what they call increased uptake. And it is very sensitive, and it's as sensitive as an MRI for making the diagnosis. It's just you lose all the other information about the soft tissues. And this is the MRI equivalent, which is where you get a focal area of inflammation at the back of the tibia. Now, some people might refer to this as a cilial tug syndrome, because you can see that that's the origin of the cilius muscle. It has three origins, actually, or three terms. It has a tibial origin, a fibular origin, and it has a central non-bony origin. And that some people might call a posterior shin splints, others might call it a cilial tug syndrome, but essentially it's a repetitive overuse. So stress fracture, I mean, the difference between a stress fracture and a stress response clinically, again, I think can be difficult, but pain at rest is a worrying sign, and if they start to exhibit some swelling and redness and warmth, that would be a very worrying sign, particularly in the foot. Now, MRI is most of the time easy to make a diagnosis of a stress fracture. Now, just to get some of the sort of sequences out of the way, people worry a little bit when they're learning about MRI about sequences, but this is a T1 weighted image, and this is an anatomical sequence, and this is what we call the pathological sequence, because this is all of the fat, whether it be subcutaneous or marrow, is suppressed. So if you have inflammation, which predominantly is water in the body, it shows up as white. So any water is white. So if you have water in the bone, that's abnormal, and that's known as bone marrow edema. The difference is that sometimes that line that's running through there which is a typical position for a proximal tibial plateau fracture, stress fracture, you might not see that on the pathological sequence because there's so much edema in the bone. So you nearly always have to have a second non-suppressed sequence to find the fracture line, and that's a typical proximal tibial stress fracture. This again is the distal location for a stress fracture in the tibia with some periosteal thickening, and this is the problem, or one of the problems with relying on x-rays. Now this x-ray actually shows it quite nicely, but that's about as good as you're ever going to get for a stress fracture of the distal tibia, faint white line. And up to half of radiographs in the presence of a stress fracture are actually normal, and that includes the metatarsal. So, you know, if I look at this x-ray here, you might say, well, what's that? Well, possibly, but you wouldn't really put your mortgage on it. Maybe that one, yeah, okay, fair enough. And then you do the MRI, and it's absolutely barn door, okay? So, again, the anatomical sequence, pathological sequence, and another pathological sequence. So that's distal tibia, that's common in runners. Now, this doesn't show too well, but the os calcis is obviously a common site for a stress fracture. Now, this is the typical location of a calcaneal stress fracture. So they parallel, doesn't really show too well, but they parallel the posterior cortex, and they're coronally orientated on imaging. And again, the plain film can or is normal. And even on a CT, it's pretty hard to make it out. But stress fractures on CT really looking, they have two forms, which is, I never quite get my head around, but if you have a stress fracture of the pars interarticularis, which is an extremely common place to have a stress fracture, they look like a fracture. In other words, you get loss of bone and then the bone separates. But in certain places that doesn't happen, and this is one of them, that actually you get the opposite, you get collapse of the bone. I'm sure it's to do with the different tractional forces that are going on through the bone, but still it's interesting because what can happen is people can look at that and go, well, that's healing. So it's a healing stress fracture. And the problem with saying that is that actually that's not correct. What's happening is the bone has lost its integrity and it's crunched down, so you've got denser bone than you should have. So I'm talking about navicular stress fracture specifically now because this is a common fracture that we see, and it's a common problem, I think, for the surgeons. And it's quite a classic sort of pattern because what tends to happen is that you get this sort of inverted Y configuration. So the fracture, as the stem is at the top, and then it comes down in inverted Y, and I'll show you that. These are the MRI images. Again, it can be quite hard to make out the fracture lines, to be totally honest, on MRI. Again, if you see a completely edematous bone, then that's always going to be abnormal. And this is the fracture line just running here. So this is the navicular, starting at the top, and we're running down, and that's a split in the navicular. Here it is now in coronal, and that's a pretty inflamed, bad stress fracture of the navicular. Now here it is in CT just running through. That one, this is the same case each time, but there's the inverted Y that I was talking about. And it's also with the blood supply, because there's a paucity of the blood supply right in the central aspect of the navicular, and that's the bit that, unsurprisingly, gets the fracture. Now, metatarsal stress fractures, very common, full stop. In the athletic group, we will see it in runners, ballet dancers, and gymnasts particularly. And in football and basketball, it tends to be the fifth, but the others tend to be the midfoot, second, third, and fourth. So just moving away from the bone now and looking at the tendo-osseous injury, because this is a more specific, a lower proportion of the injuries that we see. But I just want to talk about it because I think it's interesting. And it's to do really with an accessory bone in the tibialis posterior insertion. And there are three types, supposedly. Type 1 is quite interesting because I described that as the sort of mini kneecap inside the tendon. Type 2 is where you actually have a separate bone that's lodged onto the medial aspect of the navicular, and type 3 is when you get this hooked round navicular process. But basically they present the same, medial foot pain, most common with the type 2, and they get stress across that synchondrosis. And in runners it's a real problem because it's usually associated with abnormal biomechanics anyway. And this would be a type 2, so basically it's not a small little pebble, it's a big lump of bone on the inside of the midfoot. This is the talus navicular, and this is the accessory bone here. And this is a typical appearance now. So this is our pathological sequence. This is the accessory bone. That's the normal navicular, and that's the synchondrosis, and that's lots of bone marrow edema on either side. So this is the osteotrigonum with probably a little bit of the posterior talofibular ligament attached to it. Typical MRI, lots of marrow edema at the back of the talus, lots of marrow edema in the ossicle itself. And again, another appearance now where you've got lots of inflammation in the back of the bone, lots of posterior capsulitis, and this is the so-called nutcracker. So you put them into plantar flexion, and the space between the two areas gets smaller, and the small osteotrigonum gets nut-cracked. So again, you can see small little variations in this, which is a sort of incomplete osteotrigonum or a stress fracture through the tubercle. We try and inject them. So I'm going to talk a bit about now iliotibial band. Key thing really is about the anatomy. So you've got the skin, iliotibial band, and then lateral femoral condyle. It's often limited posteriorly when you see the information by the lateral collateral ligament. And in terms of imaging, we have to be a little bit careful because this is the suprapatellar pouch. This patient's got an effusion, but sometimes that fluid goes all the way back there, and if you're not careful, you're calling iliotibial band in somebody who's actually just got a joint effusion. So, as I said, often limited posteriorly by the LCL, and it's a classic presentation. Now, what is not so common is the development of a bursa. Now, this is about as bad a bursitis as you will see. You do occasionally see this. Probably, I don't know, 1 or 2% of iliotibial band, you get that much fluid between the two, more often than not. So this is, again, a massively impressive iliotibial band bursa. But you've got to be careful because he has an effusion, and before you know it, you're calling an ITB bursa in somebody that actually just has an effusion. But this is, slightly different, and you can see again limited posteriorly by the lateral collateral ligament, biceps femoris tendon coming down. This is much more common, and again, even this is quite a severe case because most of the time, now this is the iliotibial band, this black line coming down onto Gerdy's tubercle. The inflammation is there. The severe cases, they get it up there, but the really severe cases get it on the superficial surface. I mean, that's unusual. But this guy, he's not got much body fat, so he's obviously really gone for it on his marathon training. But to get the inflammation superficial, you're really talking about somebody who's really gone for it. So Achilles tendinopathy, this is a nightmare diagnosis. It's classically the mid-portion swelling and pain. We can make the diagnosis typically on ultrasound. You don't really need an MRI for Achilles tendinopathy. It may be that it's just clinical because you know when a patient has Achilles tendinopathy. What you won't know is whether they've got a tear in there, and that's maybe why you might send them for imaging. You might also send them for imaging to look at the degree of vascularization, because vascularization is associated with poor prognosis or worsened pain. Now, how do you treat it? This is one of the options. Put your feet up and drink tea, watch TV for a couple of years. Now, you guys will tell me a lot more about how you manage it. And I know there's controversies about eccentric loading and your other methods, so obviously I'm not going to go there. But you will see patients who come to us for an injection. And I almost never do it unless they've seen one of you. So which one do you use? Well, there is a range, anti-inflammatory. You can use steroids, and in fact, if you look at the published data on Achilles tendinopathy, steroids is actually quite good. Steroids actually got pretty good evidence base for it, but we never use it because we all know that it's likely to end up with a rupture. Obliteration of near vessels. Interestingly, polydocanol is an agent that's used for varicose vein injections, and you can use it for hemorrhoids. In fact, if you look at what's published again, the best evidence base for percutaneous treatments for Achilles tendinopathy is polydocanol. The trouble is, the guy who wrote that, Alfredson and Holberg, I'm sure a lot of you will know, he doesn't do it anymore. If there was one good treatment, there'd only be one treatment. And high volume injection, which I know is quite popular in physio, because the first papers that were published in physio journals, and I have to say, I've done a lot of them, and I really like it. I think it's it's very few times you inject a patient, you see them again in a few weeks' time to do the other side, and they've had a really good response. I mean, it's a good treatment, there's no doubt, but it is risky. But thank you very much.